Thank you, Dr. Mohammed, for this kind introduction, and welcome everybody. Today, it's going to be my pleasure to be on this amazing platform that really supports the learning of young surgeons and physicians and students and so forth. Today, we'll be talking about metabolic and bariatric surgery.
I think we can start, Dr. Asmaa.
All right, so let's go. All right, so as I was saying earlier, it is really important if you want to learn something is that you need to know what are your objectives. So we're going to talk about the objective of this lecture today and how we're going to address each one of them and try to make our learning constructed around this. So we're going to be talking about, so hopefully by the end of this talk, you'll be able to outline the burden of obesity, define what's obesity and know its classification. You'll be able to distinguish between bariatric and metabolic surgery, and you'll be able to understand some of the etiologies and the risk factors for obesity. Hopefully, by the end of the session, you'll be able to identify the candidates who are needing surgical management in terms of bariatric and metabolic surgery, and also you will be able to name and list the indication, the contraindications for the disease. We'll talk about the management, how we approach obesity, and then how can we distinguish between different types of metabolic and bariatric surgery. And most importantly, for the R4s or the R5, R5s are how to identify potential complications from each surgery, and then what is the appropriate for each one of them. And at the end, we're going to summarize what are the benefits and the measures of success for metabolic surgery. So just to start with the first objective, let's talk a little bit about the burden of obesity. So one of the most important things that we're going to ask ourselves, why do we need to know about obesity? Why this disease is important? This disease is important because it has a significant impact globally. As you all know now with the COVID, we do understand what does epidemic means, and obesity is actually epidemic. We're going to talk about about that shortly. Secondly, the impact of obesity on health, the economic burden globally, the amount of money that is being consumed on this disease, as well as the life that is lost for those patients who have the disease. So if you want to look at, so this is the world in 1975, and in the light green, you see the patient with a BMI of greater than 50. And as you've noticed, over the years, you can see a significant increase with, I don't know if you can see my pointer, but we, particularly in the Gulf region, have a very high prevalence of obesity and patients who are overweight. Same thing in North America as well. These patients, this indicates for us how that disease is spreading. When we talk about obesity, I would like you to think about it like cancer of this century. It actually growing. Here is some of the numbers just to show you between 1975 until 2016. Rates and incidence are increasing. You can see here in the United States from less than 15% or about 12% up to increase to over 35% of people have BMIs more than 30. And we know that this disease is actually cost health and a burden. So there is more than 1.9 million adults who are overweight and obese. And of this 1.9 million, there's about 650 million people. So you can imagine a disease that affects this amount of people every day. And therefore, it really needs to be, we need to study it, know how to prevent it, and how to treat it. And today we'll focus only about adult bariatric surgery. But also, as you can see, there are over 340 million children and adolescents who are at risk of obesity because they are overweight and obese. And as they grow, they will likely to become more affected by this disease. So in terms of health impact, Obesity has been associated with more than 230 conditions. It's not enough to list them in one slide, but just some of them, it's linked to about 12 or 13 types of cancers, all cardiovascular diseases, diabetes, as you all know, liver diseases, bone diseases, as well as psychological and emotional impact. So it really impacts the health of people. Here is, if we want to talk about another important thing, why do we need to know about this disease and why it's important? In this graph here, you can see that patients, they would lose about 13 years of their life if they are obese compared to those who have normal weight. So when it comes to mortality, there's up to 2.8 people dying every year from obesity. This is another table here that shows you an average of the years that is lost for obesity. So these are in adults who are age 30. You can see patients who are Black, African American, they have even a higher risk of life loss, is 14 years. If you look economically, there's lots of money that's being spent globally. In the United States, for example, in one of the reports in 2014, spent over $2 trillion to treat obesity, just right after armed forces and armed violence and war and smoking and so forth. And if you look globally as well, you can see that a lot of the expenditure is actually being spent on this disease. So as I showed you earlier, why this disease is important to know and how, what's the burden and the impact. It's important to know what is obesity, right? People have different ideas about obese people, but one of the most important things that I want to bring your attention to is that obesity, when you describe people, it often focuses on the appearance or the weight. So in 2016, the American Association of Clinical Endocrinology, endocrinologists, as well as the American College of Endocrinology, have proposed a new name for the obesity, and they called it Adiposity-Based chronic disease. And the idea is that we want to focus on the disease rather than describing a person's appearance or so forth. Now, this term does not really have to replace the word obesity, but it helps you focus more on the disease and everything else that brings it with. So what's the definition of obesity? So if you look at the WHO definition, they define it as a condition with excess fat accumulation in the body, to the extent that the health and the well-being is adversely affected. So if you have a little bit of deposition of fat that does not cause you a problem, you don't have that disease. Now, if you look at the Obesity Medicine Association, I like their definition better because it accurately describes the disease, at least for a lot of patients. So the obesity is defined as a chronic disease that is relapsing. It's a multifactorial, and we know that when we see our patient, right? They suffer just like if you are. We're going to talk more about the physiology of it in a while. But this disease, you live with it for the rest of your life, even if you get treated, whether with medical treatment or surgical treatment. It's a chronic disease. And then this disease actually causes a neurobehavioral, it is a neurobehavioral disease. It promotes fat deposition and dysfunction, and as well result in adverse metabolic, biochemical, and psychological issues. Now, we all know that a lot of people use BMI. WHO and CDC use BMI in their classification of obesity. One of the questions you answered earlier was about that. We're going to take that question next. But BMI is best for screening as well as for quantification rather than just to define the obesity. So let's move on just a little bit and talk about what's the difference between bariatric and metabolic surgery. We know that a lot of people use it exchangingly, but as a matter of fact, there are differences. So initially, bariatric surgery as it started, it is a surgery that's done on the GI tract, and the intent of that surgery is to lose or reduce your weight, you reduce the weight as a part of the therapy. Now, if you look at the metabolic surgery, on the other hand, it is mostly with the intention is to treat diabetes as well as obesity-related problem. So metabolic surgery is more disease-based and oriented. So when we want to look at our goals and we want to look at our when you choose to do or discuss with the patient you're doing a metabolic surgery, the goal and the aim will be slightly different than when you are doing it solely for the weight. And I'm not saying that patients who have who suffer from obesity and it's only weight and they still do not have, for example, metabolic diseases, that they should not undergo bariatric surgery. No, we're just highlighting the differences. And then, so with the metabolic surgery, you're looking at your hemoglobin A1C, you're looking at your glycemic control, reducing your cardiovascular risk. And also there are studies that are done that showed actually metabolic surgery is more effective than when you do bariatric surgery. So how does metabolic surgery work? Basically, there's a lot of changes that happen in the body when we operate on the GI tract, and this is just an illustration for one of the bariatric surgery. We're going to talk more in details afterward. So it alters your gut hormones, it affects your microbiota, it affects the bile acids, and also the nutrient sensation as well. And eventually, it results in a lot of physiological changes that result in the benefits of the bariatric surgery. And part of that is the weight reduction. Now, this is our first question, which is which of the following has the correct BMI classification? So we have class 3 obesity is defined as a BMI of 35 to 39.9. You want to put the question on the poll for the audience to answer. BMI of 18 is defined as normal. C, a class 4 obesity is defined as BMI of 40 to 44.9. And then a BMI of 18.9 is defined as an underweight, or E, class 1 obesity is defined as a BMI 30 to 34.9.
We're gonna repeat the questions at the beginning. We're gonna repeat them at the end, but other questions we'll bring them up during the lecture, if that's okay, Dr. Asmaa.
So shall I just give the answer for this question?
No, we'll answer them at the end. It's better to see the results.
Well, they're gonna see the answer anyway.
Okay.
All right. Okay, because that's the nice thing. So the correct answer is actually E. So class 1 obesity is defined as a BMI of 30 to 39. There's no class 4. So this is WHO classification. So as you can see here, obesity starts when the BMI is 30 up to 34.9. Class 2 is 35 to 39.9, and then BMI of 40 is your class 3. There's no class 4. And if you want to talk about the underweight, so 18 is actually considered 18.8 is an underweight. Okay, moving on to the next objective, which is what are the risk factors or what are the etiology of obesity? So here is one of our questions that we asked you earlier. So based on studies that are done on twins, what is the estimate of the genetic contribution to obesity? The correct answer for this question, shall we give them a poll, or I go ahead and answer the question?
We'll see if the audience is paying attention. We'll ask them at the end. How about that, Dr. Asmaa? We'll give them a chance at the end to see if they can answer it.
My slides will say the answer. So that's what I'm saying. The construct of the lecture is that we'll give them the question and then they answer it, and then there is the answer in the talk. So they answered earlier, right? This question? Yeah,
it came up. Yeah, this question came up.
All right, so we can, then the third question is about leptin as well. And then, so we'll talk with the next slide and see the answers. So when we talk about the pathophysiology of the obesity, you have to understand that your genetic makeups make up to 70% of your body habitus phenotype, right? So there's more than like 600 genes and markers on different chromosome regions except chromosome Y that are found that are linked to obesity. So as you can see here in this photo, these are all the sites where obesity genes were implicated. Now, so you have to understand there's a strong genetic predisposition for people to get obese. Environmental factors are about 30%. So how do we actually become obese, right? So there are lots of theories, and we're not going to talk about each one of them because there are chapters written about this, but we'll just touch base about some of them. So there are different theories of how, or not theories, but different scientific evidence to how this evolved. So we have, for example, the mediators, the leptin. We have the hypothalamic feeding center. There is the calories intake, input and output. There is the thermogenesis. There is the fat cells biology, and then there is like set points and regulations and homeostasis of weight. All these have been implicated in the pathology of the obesity. So these are some of the family mediators. And if you look at here, you have adipokinases, which are come mainly from the fat cells or the adipocyte in the body, and the leptin is one of these mediators. So leptin actually induces satiety, right? So it makes you full, does not make you want to eat. But also it generally also it's a pro-inflammatory marker. Other markers are gut hormones. We talked about that earlier in one of the slides. Insulin as well. These are gut hormones that are actually all implicated in the obesity, and there are cytokines that are involved in obesity. So you need to think about obesity as an inflammatory disease. Now, this is just a schematic, a simplified schematic a diagram of how, for example, in your brain, in the hypothalamus, how's your, there are like, or how leptin work. It have like there are first order neurons that communicate with the second, and that actually result in a behavioral output. So these, what we're trying to say is that these changes that happens at the physiological level actually influence your behavior toward eating and so forth. So that was about how we become obese, and now why do we become obese, for example. So again, metabolic thrift, genetic bases, there are metabolic diversity. We're going to talk about environmental and epigenetic contributors. All these are implicated in the pathophysiology of obesity. So one of the most important things you need to know is that this disease is quite tricky and it's changing. So as we said, big contribution is your genetic makeover, but also your genes, as we say, affect your biology. And I just showed you an example, for example, for the leptin, how it works. That will actually make you behave in a certain way. And as we know, certain behavior can change the driver environment and so forth. And that over years and years will change as well and affect your genetics. Now we're moving from the adipose cells and the fat cells. As we said, you think about it as inflammatory disease, and you move on and you see how this disease affects other organs as well. So there are lots of changes that happened at the cellular level. So there are technically there's toxins and there's cellular stress that eventually result into inflammation, which result into fibrosis, hypertrophy, and hypoxia, and so forth. And then result in inflammation. That inflammation does not only stay in the fat cell, but actually travels outside and start to spread in other organs. And in this picture, you can see how that can actually result in affecting all your body organs and resulting in diseases in these organs. So we're going to move on from that and talk about who are the candidates for surgical management. So you have one, so this is a question that you didn't have before, and you may be able to answer. So which of the following is the best potential candidate for metabolic surgery? A 35-year-old woman, Hispanic, with a BMI of 41 and a borderline blood glucose and mild knee pain. Or B, a 40-year-old man who's Asian with a BMI of 35 and a waist circumference of 41 inch and have a major depression. Or C, a 24-year-old man who's African American with a BMI of 36 and a family history of ischemic heart disease, diabetes type 2, and dyslipidemia. Or D, a 52-year-old woman who's white, a smoker, and her BMI is 40 with fatty liver and a peptic ulcer disease.
Just give the audience a few seconds to answer.
Sure.
Yep. Okay, you can move on. So can you see the answers?
All right. Okay. All right, that's great, because then that means that we're going to learn something from this session. So actually, the correct answer is actually B and not C, and we're going to tell you why it's not. So, all right. Okay. So first of all, one of the things we want to talk about is the BMI limitation. So I alluded earlier to BMI. So I showed you this picture because I want you to think about somebody whose BMI is 35 and can look that muscular, and somebody else who's 35 and they look like that. Would you operate on the muscular guy? Hamad, would you operate on this guy? No, you won't, right? Because this person, the weight, the result of the weight is actually muscle. And not, for example, a fat. So one of the most important things, so BMI is important for screening. BMI is good that you can actually scan that your patient and see, but it's not, your decision for surgery would not be based only on BMI. Now, one of the most important things is one of these studies, there are lots of studies that actually looked at waist circumference and risk of diabetes, hypertension, and vascular disease. And what they found is that in men who are, when their waist is above 40 inches or more than 102 centimeters, and women more than 88 centimeter or 35 inch, they actually have a very higher risk of cardiovascular disease, as well as from the obesity. So if you combine this with the obesity, these patients are at a higher risk. Now, one important thing is that you have to understand all the guidelines look now at Asian American. They would have different BMIs less than the Caucasian. All right, and that's why in this scenario, if we go back to the patient selection, the African American, which most of you answered, BMI was 36. He does not have any other comorbidity. He has a family history, so he's actually just an African American with a BMI of 36. So he could be that muscular guy you just saw. The Asian guy, for example, have a waist circumference of 41 inch, and he have a major depression, which is a disease relevant to his obesity, and therefore he's the more affected. Now, BMI of 41, just a border line blood glucose is not an indication. And this patient who's a smoker and have peptic ulcer disease, these needs to be treated. She needs to stop smoking, and peptic ulcer disease needs to be treated prior to having her undergo surgery. So moving on from the BMI, I'd like to present for you a very useful tool that is we use it to stage patients with obesity. It's called Edmonton Obesity Staging System, and basically the system, so it is validated and actually correlate better with mortality and risks. So what it does is actually takes a BMI, but also the EOSS score, or the Edmonton Obesity Staging Score. And as you can see here, the things that this score looks at, as I said, you have to think obesity like a cancer. It's a disease that affects everything in your body. So you have to think about obesity-related risk factors for a patient. Are there physical symptoms? Are there psychological symptoms? And is there functional limitation? Like, would this disease limit your mobility? Are you suffering from significant depression, or do you have OSA, and so forth? And according to that score, you will be staged, and according to your stage, the recommendation for you to undergo the surgery. Now we're going to move on to, so there are guidelines, multiple guidelines, and multiple societal bodies that actually focus on bariatric and metabolic surgery. So these, for example, from 2013. So we're going to go chronologically. We're going to go from before and moving forward. So in the selection criteria for bariatric or metabolic surgery, slam dunk, everybody knows BMI more than 40. With or without, you can qualify. There is evidence that you can go and have bariatric surgery or metabolic surgery. Now, if your BMI is equal or 35 and you have one or severe obesity-related comorbidity, you can actually go ahead and have the surgery. Like the surgery can be offered. If your BMI between 30 to 34.9 with diabetes or metabolic syndrome, you can also go for bariatric surgery. Now, this is the most recently that is being changed as we're advancing. So this is 2013. Moving on 2016, this is the IFSO joint statement. And then as more evidence is evolving for the benefit of metabolic surgery, bariatric surgery in diabetic patients, you can see here in their joint statement is that if your patient is diabetic, so now we're talking about diabetic, and notice here that they have put the Asian patient lower, their BMI lower by 2.5. So if we're talking about 35, it's 35, then we're talking about minus 2.5 for the Asian. So if you have diabetes and you are obese and you have class 3, you get expedited. So it's not only recommended, but you should get expedited. So expedited as well varies, right? Some countries, access for bariatric surgery is not very easy, and therefore patient takes a longer time to go. And if you have class 2, so we're talking about 35 to 35.9, then you can actually go for surgery as well, and so forth. So as we move forward, we are seeing more evidence and recommendation. Patients with diabetic should actually go metabolic surgery even with lower BMIs. This is the ADA standards guidelines for in 2017 for the diabetic care, and same thing, diabetes and metabolic surgery. So regardless of your glycemic control, if you are 40 or more, you should be going for surgery. Again, 35 to 30, so we're talking about 35. If your glycemia is not controlled, regardless of medical therapy and so forth, you should be recommended to have bariatric surgery. And now we're talking even lower. So we're talking 30 to 34.9, right? You can consider it. When we say consider, again, there's nothing fits everybody. Every patient should be evaluated individually, but these are general guidelines. So you can see if your patient falls within, you will send them for the bariatric surgery. This talk is dedicated for general surgeons, so we'll try to focus more on that. There's a lot of controversy and more evolving evidence. We'll not be discussing this because it will be beyond the scope of this talk. So same thing. So here you can see that metabolic surgery, same guidelines, have across the board, across all BMIs have shown better than just pharmacotherapy or diet for a patient. Now here we're moving, so 2018, so this is also a position statement from the SMES. So this is the American Society of Metabolic and Bariatric Surgery. And they have been discussing for patients 30 to 35. Now, these patients are not diabetic. Diabetic, we finished and discussed them, but here we're also saying for patients who are not diabetic, they are suffering from obesity, why can't they have surgery? Because you need to understand that BMI number have been picked randomly almost 25 or 30 years ago. Okay, so now we have more evidence suggesting that there are benefits, so why not have these patients being assessed and evaluated? Okay, so this is one of their position statements, and they say in these patients, you should be considering, if your medical therapy fails, you should be considering bariatric and metabolic surgery. And now that is being said, wherever you are in the world, you have to follow the regulations of your country, okay? All right, so moving on from the candidates, now we want to talk about indication and contraindications of surgery, right? So this is one of the questions that you had earlier, which of the following is an absolute contraindications? So impaired intellectual capacity, Crohn's, Prader-Willi, pregnancy, and psychiatric illnesses. And then, so here is the absolute contraindications, right? You should not be operating on somebody who is pregnant, period. So pregnancy was the answer for that question. Now, are there absolute contraindications? So metabolic and bariatric surgery is an elective surgery, right? So if there are contraindications, for example, for general anesthesia, it will still apply for bariatric surgery. If your patient is terminally ill, so they have limited life capacity, they're gonna live for a year, or they have like severe coagulopathy for whatever disease they have, you should not be operating on them. But that is not only specific for bariatric surgery, but it is like for any surgery generally. Now, I want to talk about the relative contraindication, which we have more things to discuss there. So patients who have impaired intellectual capacity, you should not deny them surgery, but these patients will need a lot of support, and you need to make sure that your system will be able to support them. They will have the family or friends or relative support and so forth, adherence. That will mainly is the challenge for these patients. Now, if the patient is actively using drug or have alcohol abuse, they should stop it for at least 6 months prior to the surgery. Now, severe psychiatric illness, if it's not treated, you should not be operating until the disease is stable. But in general, you can operate on patients who have psychiatric illnesses. Now, gradually, and malignant hyperphagia, the problem, surgeons usually are reluctant to operate on these patients because these patients, the syndrome will not be treated. The hyperphagia will not be treated. But if you have the proper setup, you should not deny these patients the benefit of the surgery. As we said, peptic ulcer disease, you can operate on them, but after you treat it. And then Crohn's disease, we'll talk about Crohn's disease here in a second. So Crohn's disease, before people thought it might be a contraindication, but it's not anymore. Okay, so there are papers there that looked at patients who received bariatric surgery, but the summary is that it is a relative contraindication. You need to assess your patient well. You need to make sure that their disease is under control and it's not active, and you're not. And then sleeve have less complications rather than Roux-en-Y gastric bypass. But again, if for example, the disease in the stomach, you have to be very careful about these patients. So on cases selection, you can operate on some Crohn's patients. Now we're going to move on and say how we manage patients with obesity. The key answer for this is that these patients needs a patient-centered with multidisciplinary specialized team. They cannot just be treated by anybody because, as we said, the disease is very complex and the disease is different from one patient to another. So in general, you would start with self-directed lifestyle changes. So diet and exercise. So people, they want to be helped, want to get over their disease. So many things that can be done in that area. If they fail, they go to professional help. And then we talk about intensive and medical therapy and pharmacotherapy as well. A lot of advances have been made now. But again, not everybody will, there are patients who will straight come to your surgery, but you have to make sure that you have worked them thoroughly and investigated everything before you offer them surgery. We're not saying that every single patient have to, like if you have somebody who have a BMI of 75, for example, it's really very unlikely that this patient will succeed with pharmacotherapy, for example, and medical therapy. But in general, all these steps have to be there in mind, and you have to think about when your patient undergo bariatric or metabolic surgery. Also, there's a lot of advances in the endoscopic and the balloon as well. We're not going to be talking about that because that's by itself is a big topic. We'll just touch upon it. And then post-surgical combination. So even if you operate on these patients and they do well, a few years after that, they might recur. Because as I said, it's a chronic disease. They can relapse, they can have issues, they can have problems. They could regain weight, or they could have a complication that may need another surgery. So you can use medication, for example, after bariatric surgery. So you use combination of treatment for these patients. And at the end, if the patient, as I said, gain weight or so forth, also there are other interventions that can be done depending on what primary surgery that they have. So I'm not gonna talk in details about this, but all I want you to know is that, because we will not be able to review everything in detail about obesity, but if you are interested, or if you know this is the area of your interest, I will highly suggest that you go read the guidelines so you would know actually how would you work up the patient, what are the things that you need to do, how you select them, and so forth. We're gonna move on now, and we're gonna talk about different type of bariatric surgery. Okay, and I know a lot of confusion is there. So we're going to talk about the modern types of metabolic and bariatric surgery. The reason I'm saying is that bariatric surgery evolved over time. we're not going to talk about that because that takes a lecture by itself. But we're going to talk about the most modern type of bariatric surgery. So you have your Roanoke gastric bypass, you have your adjustable band, your sleeve gastrectomy, you have your bilipancreatic diversion with the duodenal switch, you have the single anastomosis duodenal ileostomy, the one anastomosis gastric bypass. And there are secondary bariatric surgery. We're not going to be talking about these surgeries. So the secondary would be either, for example, as a result of a complication, whether acute or like a chronic, or for example, if they required surgery because they regained weight or they were underweight or so forth. This will be beyond the scope of the talk. Now, very important thing before we start talking about each one of the surgeries, you need to understand that the single anastomosis duodenal ileostomy and the one anastomosis or the mini gastric bypass have been recently joined the primary. Prior to 2018, it's been still considered investigational, but after 2018 March, the EFSA statement included these in primary surgeries. So these are a lot of surgeries to talk about today, but I'm just going to try to touch about each one of them because we will need to focus about complications. So here, for example, you can see the so this is the adjustable gastric band, so in general, I'm not going to talk about consent and so forth, but we're just going to talk specifically about the steps. So you have to make sure your patient positioned properly. You have to check your balloon. You have to check all your tools there. You have to put your chokers in the right place. Then you're going to do the paraflaccida approach. You're going to dissect your right across. And then again, these surgeries, you will not be doing them. You will, as a general surgeon, you will be dealing with their complications. So we want to focus more about the complications today. But it's important to know that, for example, adjustable gastric band surgery has been recently being falling out of favor. And actually, we're going to talk about that in a second. So after you put on your band, you need to fix the port under your 15 millimeter port. And then after you do that, you inject it, and then the band will control for you the area where the patient would eat. So the advantages is that patient will not be able to eat large amounts. The weight loss is not great compared to the other ones, but it does have reasonably acceptable weight loss. The good thing about it, for example, you don't need to cut anything, so you're not going to alter the anatomy, and therefore, if the patient required another surgery, you'll be able to perform it. It's reversible, so if the patient does not need it, you can remove it as well. It does not have long-term consequences when it comes to vitamins and minerals, for example, and the patient can stay for a day or less than a day, and then they go. The disadvantage, as I say, does not have a greater weight loss. So if your patient have and metabolic as well changes. So if your patient require that, that will not be the procedure of choice. And as I said recently, there are reports that showed that the reoperation rate is up to 40 or 50%, and therefore a lot of insurances are not paying, for example, in the States, and therefore this surgery is becoming more like won't be the best choice for your patient in general. Sleeve gastrectomy, as you all know, the idea is that you're gonna create a long tubular stomach, and it work by, again, I don't like to use the word restriction because we're moving from these definitions, but as you know, there will be limitation when it comes to your caloric intake. So the way you do it, you put your port appropriately, you achieve your exposure, you elevate your liver, then you start mobilizing your stomach. Very importantly, make sure you use the appropriate calibrating tube, 36 French up to 40, some studies up to 36 or 60 as well. And then as you can see here, there is a long stapler line, okay? This is very important when we talk about complications, all right? When you, after you do your resection, you're gonna extract your specimen and you're gonna send it for histopathology. Make sure that you follow it because rarely you will be surprised with something that you need to treat. All right. I'm sorry, I don't know why this is repeated. All right. Advantages for the sleeve. There's no foreign body that is there. There's no anastomosis. However, there is a long anastomotic line there, perhaps the longest that you will have in any surgery that you will perform. There is good weight loss with the sleeve. It's close to the Roux-en-Y gastric bypass as well. But unfortunately, the sleeve is irreversible when it comes to, like, you won't be able to put back the stomach, right? And then you do need to have close follow-up with the patient because they will have long-term vitamin deficiencies, for example. This is the Roux-en-Y gastric bypass. Roux-en-Y gastric bypass for a long time has been the gold standard when it comes to bariatric and metabolic surgery. In the States, it was for a long period of time, number one procedure that is done. You can see here, you create your pouch, and then after that, you're gonna go and create your anastomosis. Gastric bypass have 2 anastomoses. But now the sleeve gastrectomy is actually across the world globally is the number 1. So very important when you do any kind of bypass, when you want to divide your the small bowel and do your anastomosis, very important, please make sure you measure your bowel, make sure you mark it correctly, because when you want to do your anastomosis, you want it to do it in the appropriate fashion. As we said, Roux-en-Y gastric bypass, 2 anastomoses, you have your Roux limb and your BP limb. It's very important as well to close the mesenteric defect. We're going to talk about that in a second. I have no idea why. Okay, so advantages, for example, so excellent weight loss. As we said, have good diabetic resolution, high resolution for diabetes for patients. And then the disadvantages would be it's a more complex procedure to learn. There are more complication rate, and also adherence to follow-up is very important because patients can have vitamin deficiencies. Moving on to the duodenal switch. So duodenal switch, or biliopancreatic diversion with duodenal switch, also a procedure now that is not done so a lot. It's about 1% worldwide. The idea is that you will create, so have 2 anastomoses, but you have initially going to create a sleeve gastrectomy. Then you're going to divide your duodenum, and before you do that as well, you're going to start by measuring your bowel. Very important, as I said, from the ileocecal valve, you need to mark it accurately. So you're going to have 250 centimeters, and then from that, you're going to have your common channel at 100 centimeters, and then you're going to do your anastomosis. Very important as well. So these are, so this is the this is your elementary limb, and then sorry, it doesn't show here. I'll show you the next one. I think here, yes. So you can see here. So the final anatomy, the way it look. This is your sleeve. This is the first part of the duodenum where you do your anastomosis. So 1 anastomosis here, the other anastomosis is here. This is the common channel. So this is the only area, which is usually about a meter of your bowel, where actually your food is going to mix with the bile salt. The PPD is actually one of the best, have the best rates for diabetes resolution. And sustaining that as well, more than the Roux-en-Y gastric bypass. But as we said, it's very complex to learn, has 2 anastomoses as well. Patient would stay a bit longer. Usually, I mean, it's done laparoscopically now, so usually up to 4 days. Most of them are discharged by that time. But also it needs very close follow-up because there are rates of protein deficiency that can happen on the long term. Now, moving on to the new procedures. So the differences, for example, I want you to focus on is that think about the single anastomotic duodenal switch as it's almost like the duodenal switch, except it has only 1 anastomosis. All right, so the anastomosis basically will be from the ileocecal valve. You will measure about 300 or like centimeters or 3 meters, and then what you're going to do, you're going to use the loop to do your anastomosis, right? And you're going to do that after you created your sleeve. So only 1 anastomosis and not 2. So these are more step and details. I'm not sure if you want to go through that, but like technically, these are things that you need to think about preserving your vascularity for the duodenum when you do, for example, your dissection. Now the single anastomotic duodenal switch here. So this is your, for example, okay, so more technical. I'm not sure you guys need to know about that. All right, so this is the final anatomy. So what you're gonna see here, these are your 3 meters, and this is your loop. Your anastomosis here. This is basically an anterior reflex stitch that some do. Now the other procedure with 1 anastomosis. So this one, think about it. It's like the raw and Y gastric bypass, not the duodenal switch, the raw and Y gastric bypass, but only with one anastomosis instead of the two. So basically what happens is that, so there are two techniques. Earlier was so there are two techniques. So one technique will involve that you will have a GG anastomosis that is done end to side, and then the other technique would be side to side. So a very important thing that as well from the concern with the mini gastric bypasses, for example, is the bile reflux, right? That's what is actually prevented when you do your duodenal switch or when you do your raw and Y gastric bypass. And that's why they do the anchoring stitch, for example, the duodenal, or this configuration when you do your mini gastric bypass to try to reduce the bile reflux. When would you divide it? At 180, sorry, 150, 180, 200, there are no actually consensus in terms of the length. So in that area where a lot of people get confused, okay? All right, so now you've seen 5 types of primary bariatric surgeries. Now we're gonna see the complications. So what are the complications that can occur for these patients? So I summarized most of the complications that can occur into either complication that will require surgical or endoscopic or radiological intervention, or complication that would require medical management, for example. Now, please note that some of the complications that I've put here, I put a mark here because these complications can or may require surgical intervention, but most of the time, medical management is sufficient. So we're not gonna be able to talk about all of these, but this is a good summary for you if you want to think about, in general, what are the complications for metabolic and bariatric surgery. So, for example, when we talk about the medical complication, patient could have PE. Actually, PE is one of the most complications or DVTs that patient can die from it after raw and Y gastric bypass. Nutritional deficiencies, most of them occur on the long run. We're going to talk about them in a second. And then when we talk about the surgical, most of the, so you can bleed, right? Bleeding after metabolic surgery, most of the time it's either intra-op or very early intra-op. So as a general surgeon, you won't in general deal with that. Usually it will occur within the either intra-op, as I said, or early post-op, so within the same day or so. And bariatric surgeon will be able to deal with the bleeding. Bleeding can occur at any site, anywhere, from organs or from anastomosis, for example. We're going to focus mainly about leaks and fistulas because these can present in the emergency department, and we're going to focus on obstruction because I would think most of the patients that you will probably see as a general surgeon will fall into that. So here's one of the questions, and I don't think you guys answered this question before, so you can take this question and then we'll move from there. Which of the following statement is most accurate about diagnosis of leak post-metabolic surgery? Or we can say post, for example, raw and Y gastric surgery. Upper GI contrast study is, so A, upper GI contrast study is 80% sensitive for leaks. B, CT scan study without oral contrast has sensitivity and specificity of 55 and 75%. C, CT scan and GI studies combined together, they can be normal in 1/5 of the patient or the cases. Or D, laparoscopic or open re-exploration is appropriate diagnostic option when leaks are suspected.
We'll give the audience a few seconds.
Yeah.
We have a couple of questions, Dr. Asmaa. We'll answer them at the end of the lecture.
I can check them now while
yeah.
Let me see. Okay, so one of the questions is depression considered a comorbidity with obesity? So first of all, it depends on the onset, but yes, it can be actually a comorbidity of obesity. There's a long list of psychological and psychiatric disorders that is related to obesity, and that's why it's extremely important to screen all patients, especially those who will undergo surgery, for any psychological or psychiatric illnesses. There are actually validated surveys and tests that actually addresses that, and we do have that in our clinic in Kuwait. So yes, the answer is yes, it can be. So the second question. Are the results great after the metabolic bariatric surgery? Does patient rarely develop any complications after surgery, or is there chances of obesity seen again after metabolic surgery? So I think I answered this in the talk. So, and I will take this question again toward the end. I'll make sure that I will answer it if I didn't. All right. Okay, so we have the answers. So 38% says that the upper GI contrast study is 80% sensitive. So that is not the correct answer. So, which is great because that's the whole point of the session. So I'm gonna put the questions down and then, so, all right. So here we go. So the sensitivity of your upper GI is at best 75%. Your CT scan without a contrast, the sensitivity is about 61%. The specificity is 88.8%. Now, oral, if you add oral contrast, that can increase, right? It can, your specificity can go up to 100% and your sensitivity go down to 28%. If you use your CT scan as well as your GI studies, actually 1/3 of patients who have leak will have normal CT scan and a GI study. And for that reason, the ASMBS had issued a statement that they said that if you are suspecting a leak, you can go ahead and do a lab or your like open exploration of the patient if you are suspecting a leak. So in case if you have a negative radiological study, but clinically you still have the suspicion that the patient have a leak, you can go ahead and take the patient, do your diagnostic laparoscopy or operate on the patient. Okay. Now we have the second question. So where do most leaks occur post laparoscopic sleeve gastrectomy? They occur near the pylorus at the stapler line, or B near the incisura angularis, or C below the GE junction at the stapler line, or D at the stapler line anywhere in the stomach. So I think they took this question before. So we're gonna, you want them to answer this question, or shall we just move on? All right, I think I'll just move on. All right. Yeah. So I think one of the most important things that we need to understand when we talk about leak, because we're here like combining all leaks that can occur with a sleeve or with the Rowan-White gastric bypass. But just like any anastomosis that you do in colon surgery or any other surgery, there are things that can cause that. So, you know, you're creating something out of nothing. So technique can play a role, right? So poor technique when you configure your anastomosis or when you construct it. If you have excessive tension, for example, in surgeries where there are anastomoses. And then if you have a stapler line bleeding, for example, it can increase your chances of having leak. And also if you have, for example, tissue ischemia. So for example, we have more tension at the mesentery, and then you end up having, for example, some tissue ischemia. Now there are patient factor that is related. So if, for example, the presence of poor nutrition, patient is actively smoking or have history of smoking, or patient is cirrhotic or have renal failure, these are things can actually affect your leak. Now, site of leak is important. So as we said earlier, so you have your sleeve and the Rowan gastric bypass. So in the sleeve, for example, the most common site is actually at the angle of His, which is just below the GE junction, right? So almost 80% of the leaks occurs there. Now, as I mentioned earlier, sleeve has a very long stapler line, so it can leak from any point, but these are the most common site. And the theory behind the anastomotic leak in sleeves are alluded to the increased intraluminal pressure, right? So you have the stomach, and then now you like restrict it when you cut it, and it's too small now. So you have increased intraluminal pressure, which also can result in increased laminal radial force, and that can lead to the disruption of your anastomosis line. Sometimes as well, when your angulation, you could have partial obstruction of your incisura, and you could have relatively like a tissue ischemia because generally like the stomach is well vascularized. Also the tissues at the cardia are thinner, so sometimes that area can leak. Now, if you look at the Rowan Y gastric bypass, so you have so sleeve have only one long line, Rowan Y gastric bypass have multiple triple lines, right? So the most common site is actually the gastrojejunal area, is the area where it leaks the most, but it can occur anywhere. It can occur down in the JJ or from your pouch or from your laminate, for example. Main cause as well, tension can cause that, and as we said, tissue ischemia. I did mention, for example, as when you divide your mesentery, you could cause that, right? Okay. Here's another question. I don't think they answered this question before. In patient with suspected postoperative leak, which is the first vital sign to be abnormal? A, increased respiratory rate. B, elevated blood pressure, systolic blood pressure. C, you would have fever or high temperature of 40 degrees, and then tachycardia of more than 100.
This will be a quick one, just a few seconds.
Yes. All right. Let me see if there are questions.
We'll show the results.
Good. So we have 55% saying it's tachycardia, which is great. So that's the correct answer. One of the most important things you need to know, anastomotic leak are rare, right? They occur in Rowan Y gastric bypass, probably around like less than 1% in both. But it's important to know that these complications are very risky. They can cause peritonitis, sepsis, chronic fistula, and so forth. And it's a preventable cause of mortality. So it's best to be diagnosed, like you really need to diagnose them very early on, have a high clinical suspicion, and act very quickly. Important concept that you need to know when you want to manage these leaks is that it depends on the extent of the disruption of the leak. Is there abdominal contamination? Where is the site of the leak? And the time of the presentation. Many patients can go with supportive management early on. So let's not forget to always start that. So your antibiotics early on, your fluid resuscitation. If your patient needs nutrition, you have to start that. These can be acute, early, or late, or chronic. So acute if they're like less than 7 days. Early is less than 6 weeks. Late is between 6 and 12, and then chronic more than 12 weeks. So for most patients who comes in with early and acute leaks, if they are hemodynamically stable, maybe you can do non-operative management, maybe there's a collection, you're gonna drain it, etc. But many will need reoperation. You need to do a washout. Sometimes you can't close the defect. You can choose to close it or not, depends on the tissue, for example. You can use T-tubes to place in the defect. I'll show you a picture about that in a second. And then you could also you need to put lots of drainage. So a lot of abdominal drains are probably needed around that area. Some patient may benefit from stents. We'll show you a picture about that. Not all patients, it will not be suitable for all patients, but this is one of the tools that you could use to treat the leaks. If they present late or they have chronic, then you're talking more about proximal, like maybe you will need to do proximal gastrectomy and esophageostomy. That will not be, it won't be you who will be doing this. So this is, for example, a picture of a T-tube here on the right side in the B. You can see that you will put the T-tube into the hole, for example, there, and extend it extracorporeally. And then the idea is that what you're going to do is that you're going to leave it there for about 4 to 6 weeks, and then gradually you're going to try to track it out to create a controlled fistula. The other photo here is about stenting that you can put. We're not going to talk about the details of how to place them and so forth, because that's a different talk, but this is one of the things that you can do. This is if your patient have a chronic leak, and then eventually you need, for example, to resect that part and do your esophageostomy. Another question here. So we're moving on from the leaks to complications with hernias. So question number 9, internal hernia cannot occur in which of the potential areas if the patient have an ante-colic gastric bypass? Peterson space, jejuno-jejunostomy space, or the transverse mesocolon space.
Just 10 more seconds and we'll end this
Sure.
question.
I'm going to try to fly with the next slides because I'm just like looking at the
No
time.
problem. No problem.
Yeah.
Take your time. And we'll just show the poll results right now.
All right, so 38% said C, which is the right answer, the transverse mesocolon, and 41% said the jejuno-jejunostomy, but this does not make sense. All right, here. So let's show you the anatomy here. All right, so when you do your Roux-en-Y gastric bypass, areas of potential when you do, so there are two techniques, right? There's the antegrade and there's the retrograde technique. And the antegrade, there's only two defects that you would create to do your anastomosis, where when you do the retrograde, there are three defects that you could create. So if you look here, for example, you have the where the distal anastomosis area between your JJ, where the arrow is coming there. I don't know if you can see my pointer, but that is one of the spaces that can occur in the anti and the retrocolic, right? And then the other space will be here, right behind your limb, between the the mesocolon and as well as your limb. So that's the second area. Internal hernia is actually very common when we say very common, because it goes up to, like, one of the reports is up to more than 6%. And now there's one of the reports from Cleveland Clinic that they looked at all their obstructions, and then they found that the most obstruction patients would have on gastric bypass is actually internal hernia, right? So I'll show you the next picture. Maybe it will show you even better because it's a straight comparison between the retro and the anterior. So in the ante-colic, you'll have only two spaces where you could have the hernia from. As we showed you earlier, this is your GJ, and this is the area, this is the Peterson, we call it Peterson space. Where in the retrocolic, what you have to do is actually you're going to create a defect into this area to bring your anastomosis up to the stomach here. So that's a third space, and that's the mesocolic defect where another hernia can occur, like the in that area. All right. We're going to take a question here. The question is a bit long, so I will read it out for you. So 28-year-old man presented to the emergency with abdominal pain for 6 hours. He had a history of gastric balloon insertion about 3 months ago. Initially, his weight was 103 with a height of 175. His BMI was 33.6. His current weight is 95 kilos with a BMI of 31. The pain started during a massage session. He had acute onset, sharp, and then diffused. He had nausea and vomiting. His vital signs showed a heart rate of 115, blood pressure is 120/50, respirator is 26, standing 98% on room air, and a temperature of 38.6. Now your focused abdominal examination revealed epigastric tenderness and gardening, only in the epigastric area. You started him on analgesia, IV fluid, and you send you a workup. What is your next step in the management? A, are you going to do an urgent abdominal x-ray? B, you're going to do an urgent CT scan with an IV and oral contrast. C, you're going to do an urgent diagnostic laparoscopy. D, you're going to take the patient for urgent open laparotomy.
So we'll just reveal the answers as the question is on the slideshow. Give the audience just a few seconds to answer the question. Might I add, Dr. Asmaa, I'm loving the images and the videos during the lectures. It's very helpful. I hope everyone is enjoying it.
It's really a very large topic to be shortened as much, you know, but I think I'm hoping that the objectives will make the topic very clear hopefully for everybody, and give you some practical information that you will use when you see these patients. All right, so I don't think anybody is answering. We're not seeing I'm not seeing them, or is it?
Can we just everyone just answer the questions, and we'll reveal the answers again.
Okay, I'm going to take some of the audience questions while does patient rarely develop any complications? So okay. So does patient rarely develop any complications? So what I would say, bariatric and metabolic surgery is a very safe surgery, generally speaking. Complication mortality and morbidity is very low, even lower sometimes than very small amount than ante-colic, believe it or not. Okay, so it's very safe surgery, but it has to be done in the right place with where you have all the setup and the proper services that the patient needs. In terms of, there's another comment for cost-effective and more acceptable point of view, which procedure you do recommend? So you cannot recommend any procedure in general. All the procedures are valid and needed for a specific patient. So you have to give a patient's profile to be able to actually to pick the surgery. All right. Do you have the poll results?
Yeah, we'll just reveal them right now.
Good, perfect. Okay. So 37% that they will take the patient to urgent diagnostic laparoscopy. All right. And then 31 said they will scan the patient, 23 said urgent abdominal x-ray, and open laparotomy 10%. All right. So maybe the question tipped you off a little bit. What I wanted you to know from this scenario is the following. This is a patient who had a balloon, and he comes to your emergency very early on, within 6 hours of their pain. They're hemodynamically stable. Clinically, they're well. You have to think about gastric outlet obstruction, right? So your way to go is actually, you can start, and then the specific reason I put urgent on everything, the patient is stable in the emergency and they're well, you can do your x-ray. The reason I'm telling you, the x-ray is not only diagnostic, the x-ray, but if your patient had a balloon, x-ray, you can get it in the same time, where if you want to do the CT scan, you need to prep them. So your first x-ray, you're gonna do it right on site because your patient is stable and it's gonna take a few minutes to do, so you don't have to panic. If your x-ray shows the balloon is there, because now you don't know which balloon, right? But let's say, for example, because there are air-filled balloon, but you can actually see you can see the balloon identified on the x-ray. So if you see it and it's give you the diagnosis of gastric outlet obstruction, fair and well. You had your diagnosis, all you have to do is go ahead and do your endoscopy. Now, if your patient is unstable, then that's a different story. You could do urgent endoscopy. If you are in doubt, you do not think this is the reason, and then you can go ahead and discuss the other things, do a CT scan. But I wouldn't take the patient to the operating room without knowing the diagnosis. So definitely laparoscopy and open will not be the right answer, especially your patient is stable, they're just early on, they're healthy, and then you can actually have time to work them up. So for gastric outlet obstruction that is secondary to balloon insertion, what you need to do, the treatment is actually endoscopy. So very important to get your expert endoscopist there or expert bariatric surgeon. But if you don't have expertise in this kind of cases, you should not be doing them. And then what you're going to do is that you're going to do the procedure under general anesthesia just in case. Now, the presentation is very acute, but also you don't know. So you have to make sure that the patient is safe. And in case you have to convert or operate, you'll be able to do it because the patient is under GA. You have to consent them as well and explain for them the possibilities. And after the removal, generally, the patient do well. Another complication that can happen as well is strictures. Again, these are less likely to present for the general surgeon, but it's good to know about them because they may present for you early when you're during your on-call. Incident is it's very variable. It can be from 0.9 to 34%, right? And you would say that this is a stricture if your scope wouldn't pass. So if your 9mm scope wouldn't pass, you would identify this as a stricture. There's a small picture here, a demonstration of that. Usually, typically, they present these patients between 4 to 6 weeks after the surgery, and then usually there are complications that they won't be able to tolerate the solid food, and then also the liquid as well. Most of them, however, present within 90 days. But rarely they would present like after a year or so. The most common site, as we said, is the gastrojejunal stricture. That's the area where most of these strictures then occur. In terms of the management, so diagnosis, you can actually diagnose it just by history and endoscopy. And then endoscopy is diagnostic and therapeutic at the same time. It might require multiple sessions and use a balloon dilatation to try to dilate that, but patients have reasonably good results after that. Another complication that is rare, uncommon, is intussusception for patients who have bariatric surgery. So for example, in this CT scan, you can see what we call target sign here. So what happens is that your distal anastomosis will actually be the lead point and intercept telescope inside the bowel. Many of these cases actually can resolve spontaneously. However, you do have to admit your patient, put them in PO, and when you take them to, if everything resolves spontaneously, that's fine. If not, you would take them to the operating room, start with your diagnostic laparoscopy, try to identify where's if that was the site of the intussusception, and then you will have to reduce it. The segment has to be as well resected, again, depend on your examination. If you go in and there's no intussusception, you should not be doing anything. You will leave the patient and just abort the surgery. Now, this is a picture for a question that I'm going to show you. So take a look at this question. There's already a pointer that points out where the abnormality is. So here's the question. 32-year-old man presented to the emergency with severe abdominal pain for 2 days, had a history of balloon insertion about a month ago. Initially, his weight was 120, height of 186, and a BMI of 34.6. Now his weight is 110 and his BMI is 31.7. Had a gradual onset of crampy abdominal pain, and then there was nausea, vomiting, and there's urine staining as well. Heart rate is 110, blood pressure is 112/52, respiratory is 24%, statin 99% on room air, and he's afebrile. Your examination revealed diffuse tenderness with equivocal peritoneal signs. You start him on IV fluid, you give him analgesia, you draw your blood, you put your NGT, and then you send him for a CT scan with IV and oral contrast, and the image is the image that I just showed you earlier. I have another picture here, you can look at it here. So what is the most likely diagnosis? Acute cholecystitis, A, acute cholecystitis, B, internal hernia, C, migration of gastric balloon, and D is perforated viscous.
We'll show the poll. Yep. Let everyone answer for a few seconds.
I think that is probably the last question we have today. We're approaching the end of the lecture with most of the surgical complications discussed so far. Let me take if there are more questions here. All right, so there's a question about intellectual disability. Is it a contraindication? So is it a contraindication as the patient cannot give a consent? In another word, if the patient's family is forcing the surgery, would it be done? Okay, so this is a complex situation because now we want to talk about if the patient is a minor or an adult, and if they do have a guardian or a family or somebody who is responsible to make, like legally responsible to take their decisions. So often surgery cannot be forced in general. However, if the patient, that's why I said it has to be in a multidisciplinary setting. So you will have your psychiatrist, your psychologist, your pediatrician, if the patient is a minor. These people will be involved in the discussion and the assessment to say if the patient should go first or not, and then how can they help this patient to go. But if the patient have the will, because these things that you have to really think about when you offer surgery for somebody, because compliance is extremely important for the success. So there's another question about bariatric surgery can be done in hypothyroidism. So if you're talking, so in general, before undergoing any bariatric surgery, thyroid function test is one of the tests that you have to do because you want to make sure that, for example, if the reason is weight gain secondary to that or not, you need to treat it you need to treat it first, and then you can proceed with your bariatric surgery. Okay, shall we show the poll, and then I'll take more questions after?
Yeah, we'll show the poll answers right now.
Perfect. So you guys, fantastic. I don't need to talk about this. So this is migration of gastric balloon. 47% got it right. So it's not perforated viscous. There's no gas that indicates that. So it's 11% who said acute cholecystitis, gallbladder is not there. All right, so gastric balloon migration. So now you already know that the patient had a history of a balloon insertion. You have to think that this is a possibility. So you're gonna start with your supportive care, and then you're gonna decide, you're gonna take the patient. Usually balloon migration, they don't migrate as they fall. Usually what happens, they deflate, and according to that, they migrate. And that was the trick in the saying that the urine have stain. So there are some of the stain that was in the urine. Now what you're going to do, so this patient, you're going to consent them, you're going to go laparoscopically initially, and you're going to make sure that you're going to handle the bowel very gently as you go, because you want to make sure, first of all, you need to find where the area is. So CT help you find it, that's fantastic. What you're going to do is that you're going to perform your enterotomy proximal to where the balloon is, and then you're going to try to milk it back to the enterotomy. Extract it with caution, make sure if there's more fluid, maybe you can suction it using a needle or so. And then as you extract it, you can close your enterotomy with absorbable suture, and you have to make sure, inspect everything that there's nothing else. And then after that, you can finish the surgery and take the patient to recovery. Usually they do well after that. Some in the literature err at the side of, again, these are not very, we have to take in consideration balloon migration is a very rare disease, right? So some people will wait some time to resuscitate the patient, for example, if they're not stable, or they would see if they can pass the balloon, but I don't think that's a good idea. I think if you have balloon migration, you would actually go and take it out. In any cases of devices that you would do that will go malfunction, for example, such as balloon in this case, you have to report for the manufacturer. You have to inform them what happened to the balloon. So this is one of the studies that looked at the sensitivity for staining of the urine. So it's about sensitive in about 60–62% for patients who have balloon deflation and migration. We're going to move on for stomal ulceration. As we said, most of the time these patients are treated conservatively, so you'll not need to operate on them. You have to make sure that if there's any, unsafe smoking, all this kind of stuff, you have to make sure that that is eradicated. And then the treatment mainly is actually PPI, but sometimes patients have H. pylori, so if they have H. pylori, please treat the H. pylori. In rare cases, you will have to actually go back to the operating room and try to revise the pouch. Or sometimes what happens is that there are actually foreign bodies, so endoscopy is really important. You could have a stitch sometimes that comes on, or stapler line, and that could cause the ulceration. So in that case, you have actually to remove these parts. Dumping syndrome is one of the also medically treated complications that can occur. Usually results from high dose of simple sugar that could cause the symptoms. There are early and late dumping syndrome. 15% of the patient would have systematic changes, but most of the time, all you need to do is actually educate the patient very well in terms of what they eat, how they eat, and so forth. And you can avoid that you will need to reoperate to, for example, to go back to normal anatomy and reverse the bypass to avoid dumping syndrome. Development of gallstones, also very common, can happen after surgery, especially with acute weight loss. It's very important that before, in the past, a lot of patients used to have prophylactic cholecystectomy. For now, we don't do it prophylactically. If you're doing a bypass, you can use the ursoidal to decrease the chances of having stones. Moving on to nutritional consequences. Again, they need a lecture on their own, but just to know that these nutritional consequences are very, very serious. They can present with permanent neurological deficits and damage, and they are very common in bariatric patients. All the surgeries that we discussed, except for the the band, all of them can have either iron deficiency and so forth. Okay, so make sure your patient takes their supplement. Now we're going to just quickly summarize the benefits for those who ask about the benefits of the bariatric surgery and how we measure success. So very important here is that metabolic and bariatric surgery have shown like with high level of evidence, that there's resolution of comorbidities in different degrees across all the type of surgeries. But for sure, there are resolution of comorbidities. It reduces the cardiovascular risk, improve glycemic control, and then you have a weight loss and weight maintenance and improve quality of life. So these are some of the publications here. For example, in JAMA 2015, that showed surgical patients have way much less cardiovascular and mortality risk compared to patients who did not get surgical treatments. And same thing when you look at medication, because it's not only the resolution, but also requirement of medication, much less patient requiring medication after bariatric surgery. When we talk about the success, so there are goals for the patient, and there are the goals of you as the surgeon and the caregiver for we look always at what's the glycemic control, what's this and that, but also it's important to, because this is the patient disease and this is the patient life. So patients have expectations and goals, their satisfaction, their well-being is extremely important. So this you have to take on early on when you want to choose their surgery or what kind of treatment you want to use it for, because this is actually one of the important measures for success. Then, as you know, a percentage of weight loss and so forth, these are also, if you're looking at bariatric surgery, that some of the measures that are being seen. So in summary, we talked about a lot of things in bariatric surgery. We talked about the burden, we talked about definitions, about obesity, the ABCD, we talked about bariatric and metabolic surgery, what are the difference between them. We touched upon the physiology. We know that genetics make a big contribution to our etiology, but also it's an epigenetic disease, so environment can affect that as well. We talked about how we would select our candidates and what are the indications, the contraindications. We talked about different kind of surgeries and what are the complications that can arise from them and how can we treat them, and then how we would measure the success of the patient and what are the benefits of bariatric surgery. So I'm gonna leave you with a quick last slides here to give you like a general concept about if you come across any complication of a bariatric surgery, after you know and learn about that, you have to know that history is extremely important, knowing what kind of procedure your patient have. If you can reach out for the surgeon or the person who operated on that patient on a timely fashion, go ahead and do that. If your patient have the surgery in your institution, go ahead, check the OR reports, because understanding the surgery that the patient have, the anatomy, is very, can really help you at the time when the complication, we talk about surgical complication arise. Get imaging if you can, review it with your radiology, don't just read the report. And if your patient presents with sepsis, you have to go with all the principles about sepsis and source control. You have to think about damage control when you go into the operating room. I wanted to show some videos today, but I know that the topic was very, the time will not be sufficient, but you can talk a lot about the complications, but when it happens really on the floor, can be a completely different nightmare. So being focused, being organized, knowing what are the things, preparing, rehearsing before you enter the surgery is very important. Ask for help if you need it before you start, and always assess the patient physiology thoroughly and regularly. So the time when you see the patient in the ER would be different than the time maybe when you take them to the operating room, is different when you take them to the intensive care unit. Try to go with laparoscopy. Again, I wouldn't say always go laparoscopy, but I always say that it depends on what you have. Laparoscopy gives a great advantage in obese patients, especially if you're dealing with the proximal pathology. So proximal stomach, proximal anastomosis. So think if this is something that you want to go. And then if you in the operating room, starting with your laparoscopy and you think you cannot get it, please convert to open. Conversion to open is actually indication. It's not a complication. Sometimes you would have very bad cases where you need to, visuality is compromised. Ports, you can put them, you don't have the space because many patients get multiple surgeries. They get abdominoplasties, which can restrict actually your performance. So think about all that when you deal with bariatric surgery. Thank you. Okay, so I'll take a few questions. So some of the questions, so I asked some of the questions that talked about genetic factors, kind of bariatric surgery help in stopping it past in further generation. So the answer is yes. There are actually some of the research on pregnant women who actually were obese, underwent and had siblings prior the surgery. And after they had surgery, they again had siblings, and they found that the rate of the obesity in siblings born after bariatric and metabolic surgery is actually less than the previous kids. And the science is evolving, and there's a lot of studies, but yes. So this is one of the things that you could think about. Also, one of the things they said is that we didn't talk about here today, which is prevention. But prevention can play a major role into preventing more people becoming obese. So that will need a lecture, but just the answer is yes in general. There's lots of things that can be done for sure, and that's why we need to raise awareness. Actually, the first 1,000 days of life makes a huge contribution to the chance that a person become obese or not. There's a question about, is it common that gastric obstruction causes guarding and tachycardia and fever? I would say yes. Again, it depends on the scenario, but it is possible. Is gastric obstruction needs a vagotomy? So not in the scenario that I gave you, because in this scenario, the cause of the obstruction was the balloon blocking, right? So once you relieve that, everything should go back to normal. So there's no indication for vagotomy at this stage from a balloon. How sleeve is considered a malabsorptive surgery and not restrictive. So this need a lot of, so as we said, I showed you earlier, so there are a lot of hormonal and gut changes that actually in surgery. Sleeve is not, so again, restrictive and malabsorptive. We're trying to avoid these terminologies now. These are all terminologies. We do not use malabsorptive. We do know, for example, when you do with bypass surgery, you could reduce the absorption of some of the vitamins and nutrients, but you are not causing malabsorption. Sleeve is not considered malabsorptive, but there are gut and hormonal changes and a lot of physiological changes that can actually improve your metabolic profile, not only solely secondary to the restriction or the size of the stomach. So which color of the urine with the balloon rupture? So it depends on what you injected the balloon with, right? And then do we perform cholecystectomy and duodenal switch? So in the past, yes. It used to be done routinely, but now you do not have to do it. And I understand the concern is for access, but you don't have to do it for all the patients. Is the only difference between bariatric and metabolic surgery is the reason you're doing it because what I understood the same surgical technique is in what the, yeah. So again, why you're selecting a procedure for a patient is very important. And then what are your targets out of the procedure? So if you have a patient who is coming, who's diabetic, hypertensive, or have other comorbidities, metabolic comorbidities, that is secondary to diabetes, that would reduce the cardiovascular risk, diabetes, etc. And you're selecting a surgery to improve that, then you are doing a metabolic surgery, right? Because that would be your goal. But if you have somebody who comes to you and they say, I'm 100 kilos and I just want to lose weight, and that's the goal, that you will only do it for that, regardless if they did in that case. So that's, I hope I answered that question. is a prokinetic medication needed post-sleeve and and dose operation effective mortality? No, you don't need it. You don't have to, there's no science, there's no studies that supports that you absolutely have to use them. I think you can selectively decide who patient needs what. So PPI, so there's a question for how long PPIs did you prescribe? So there is a lot of, there's a lot of studies that are being released now that is related to the poor outcomes of patients with PPI, not only in bariatric surgery, but also even in critical care. So we have to use PPI with caution. So in general, if your patient used to be on PPI for a specific reason, you need to know what that reason, and then you can decide, but you do not have to start all your patients on PPI. We didn't talk about GERD post-sleeve, but if your patient have it, you could use for that. And I think we have to stop because the time is running and people have commitments, yes.
Thank you, Dr. Asmaa. Thank you, everyone who joined us. It was a very informative lecture and the visualization was just excellent. Thank you so much. Any remarks, Dr. Asmaa, before we...
Thank you. Thank you for having me here today. And I hope that people learn something about bariatric and metabolic surgery. I mean, there's a lot to learn here, but if there's anybody who is interested or have more questions, I'll be happy to, you can forward my email and I'll be happy to answer them. Thank you so much.
Thank you. Thank you, Dr. Asmaa.
Thank you.
So,
Bye-bye.